I'm Jenny. This presentation is on shoulder dystocia. Here are my references, including Queensland Ambulance Service Guidelines, the Royal Australian New Zealand College of Obstetricians and Gynecologists, and a journal article. So first of all, I'm just going to quickly go over what shoulder dystocia is. I'm going to talk about who's at high risk, some signs of shoulder dystocia, and then I'm going to go through a delivery, the 3 external manoeuvres and the 4 internal manoeuvres. So first of all, shoulder dystocia is a difficulty encounter when delivering the shoulders of the baby. So the birth of the head occurs, but the shoulders are stuck. So normally the anterior shoulder is stuck under the symphysis pubis, but sometimes both shoulders can be stuck as well. It is pretty hard to predict. I don't really know until the head's out that it's happened. But there is some high risk patients that could alert you that this patient's going to have shoulder dystocia. So this includes a prolonged second stage of labour, mum having diabetes, so gestational diabetes, previous history of shoulder dystocia with other deliveries, small maternal pelvis, mum having obesity, and also baby being more than 40 weeks gestation, so a bigger baby. So signs of it, of shoulder dystocia is once the head has come out and the shoulders fail to deliver with some gentle traction there. So if the head's come out and within 60 seconds, if the shoulders haven't delivered with a bit of gentle traction, then you have shoulder dystocia. So you can tell if the head doesn't restitute, so it doesn't externally rotate, and it's just like a turtle sign there coming in and out. Sometimes the chin burrows into the perineum there. So it is time critical. So once the head's out, the pH drops of the umbilical cord before then and the start of breathing. So they're really high risk of an asphyxial hypoxic brain injury to the baby or death. So obstetrics, the Australian New Zealand College of Obstetrics and Gynecologists say that you can do it under 5 minutes, then it's a low risk of ischemic injury. We're going to aim for 4 minutes in this. So complications, hypoxic injury to baby, mum can have a PPH, so postpartum hemorrhage, trauma to baby, trauma to mum on the way out. So baby fractures, brachial plexus, cerebral palsy can occur. So now I'm just going to go through, if we're called to mum, we know she's in labour, say she's 40 weeks, turn up, mum's on there, we want to go through safety always, so gloves on, PPE on, scene safety, make sure mum's safe as well. So we get here, she's had regular contractions, we've aided her to push, we've controlled the head, delivery of the head, head's come out, we've got all the history from mum, we know it's a normal delivery, etc. We've got the head out, and then we gentle traction with the head guiding the head out, and there's no movement there. So we've tried for 30, 60 seconds and the shoulders are stuck there. So what we want to do is we want to work really quickly through some manoeuvres to try and relieve the baby so there's no injury. So things we want to think about is calling for some backup, so someone higher qualified, if you're rural, maybe doctors, neonate resuscitation team, anything like that that you can get your hands on. In the city, if you've got intensive care paramedics, or even just a second crew to help out with this, because there's a lot to do and there's high chance of injury to mum and baby. So get that going. We want to talk through mum. Mum, your baby's a bit stuck. We're going to have to do a few things quickly. It's going to be quite painful, so we want some pain relief for mum as well. So first of all, so we've got 3 external manoeuvres we want to go through first. The first one is Mick Roberts. Now this has had really high success rates, research is showing, so this is one we want to go straight to. We want to get mum to come right to the edge of the bed, so just ease mum to the edge of the bed, help her there. We want her knees right up, so knees right up to her chest. It could be quite difficult, she's quite tired, she's been labouring for a while, so we might need people to help hold those knees right back. So the idea of this is to straighten the lumbosacral angle and increase the anterior posterior diameter of the pelvis. So we want to increase that area so hopefully the baby's shoulder can pop in under that symphysis pubis there. So we want knees right back, up to the chest, and your second is some gentle traction on the head. We don't want to pull, just a bit of gentle traction to try and deliver. So each manoeuvre we want to try for about 30 seconds. If that's not working, we want to move on to the next one. So we want to McRoberts, which is knees up, gentle traction there. If that doesn't work, we're going to move on to Reuben 1. So we can keep Mum in McRoberts if someone can hold her there, and we want to move on to Reuben 1. So this one, we want to do 30 seconds of CPR sort of motion. The idea here is that we're pressure on the symphysis pubis to try and relieve the anterior shoulder of the baby. So the idea is to slip that under. So we're shortening that bisacomial size of the fetus. So we're trying to push under there. There's been some research that I don't think there's any difference between techniques here, but you can do 30 seconds of compressions and 30 seconds of rocking, just trying to relieve that baby under there. So that's Reuben 1. If this doesn't work, we want to move on quickly to Gaskin, which is all fours. A lot of literature has this later on the piece, however, we want to try and avoid those internal manoeuvres. So we want to get Mum to rotate onto all fours if she can do so safely, and try and deliver baby that way. The idea again is that movement and that increasing size of the pelvis to try and get that baby out. So that's our next one from there. So we've got McRoberts with the knees up, Reuben 1, which is to relieve the anterior shoulder, and then we've got all fours. So if these don't work, we need to move on to internal. Once again, thinking about possible for transport if you're close to hospital, backup, pain relief, lots and lots of reassurance to Mum. So now we're moving on to Reuben 2. So we can continue, one person's continuing trying to relieve this pressure on the symphysis pubis, and we're going to put a couple of things into the vagina, and we're going to push on the anterior shoulder downwards. So we want to push the shoulder towards the baby's chest. So pressure in under here. Once again, the idea is to try and relieve that underneath the symphysis pubis and deliver. So we want to try this for 30 seconds. If this doesn't work, we move on to the wood screw. So wood screw is pop your things into the posterior shoulder. We're pushing on the front and pulling underneath this kind of motion to try and relieve baby underneath the symphysis pubis. Once again, 30 seconds here. If this doesn't work, wood screw 2, which is alternate your fingers, it goes the other way. So we want to push backwards on the anterior shoulder and forwards of the posterior shoulder, once again trying to relieve that. So 30 seconds on this one. If this doesn't work, then we move on to delivering of the posterior arm, sorry. So we want to get our hand in here, and we want to grab hold of the wrist, go over top of the baby's head, pop that shoulder out, and then deliver the baby. So it's a little bit, this makes it a little bit difficult, but we want to grab hold of baby's wrist and pop that arm out. So once we have that arm out, we should have enough room to deliver baby. So just gentle traction here, I wouldn't be pulling, this now is a little bit difficult, but I wouldn't be pulling down. So it should be just some gentle traction. So gentle traction down. Once we have baby out, we pop baby straight onto Mum for some skin-to-skin contact. And we want to do some drying and stimulation. So dry baby off. Some good stimulation, skin-to-skin, warm contact. The baby's looking good, good cry, then we can leave it on Mum wrapped up there. And we want to do that at 1 to 5 minutes. So with that, we want to look at heart rate, if it's 100 or below, if it's breathing, if it's got a good cry there or there's no breathing, if it's got a good grimace, so if there's facial movement, pulling away, stimulation like that, activity, muscle tone, if it's actively moving limbs or not, or no movement, and then we want to look at the skin colour as well. So we want to perform that at 1 and 5 minutes. We also want to deliver the placenta. So we want to wait till the cord stops pulsating. So we want to wait a few minutes at least, up to 5 minutes to clamp that cord at 10, 15, 20 and cut that. So with the placenta, we are either doing physiological management or active. So physiological means she'll just be delivering naturally. She doesn't want oxytocin. With that, we let the placenta come out naturally. So for them to come out, we want to check all the membranes, pop that in a bag, and take that to hospital. If we're doing active, then we will be giving oxytocin, and if that's the case, then we'll be guarding the uterus and a really gentle traction of the cord to deliver that placenta. So big things with this, if it's been quite a traumatic delivery, we want to look for any tears around the vagina that needs any pressure. We want to look, monitor for blood loss. So we want to put pads in there so we can see how much blood loss is coming, and prepare for postpartum hemorrhage of some large IV access as well. We also want to be well prepared for a neonate resuscitation if it's been a hard labour like this. Early transportation and early notification as well. Also, there are some other steps that they do in hospital, so with shoulder dystocia. So if you can't achieve that delivery, get to hospital really quickly, but hopefully all these manoeuvres work. Thank you.